Jason, and thanks for putting this together. I think it to be quite timely. These are my disclosures, none of which are particularly germane. My biggest conflict of interest is I'm a spine surgeon, and I'm paid to do what I do. And I think at some level that's kind of what we're talking about here. My assumption in coming here is it's termed an epidemic, and you saw in Jason's introductory slide just how huge a problem this is. To me, it's almost an opioid crisis again. Started well-intentioned early in my career. I remember walking on the hallway and we had a pain management center. It looked like that Ghostbusters no pain red circle with line through it. And here we are 25 years later swinging back the other way. So I do think we have a problem. I think a topic like this, I think a forum like this is maybe we can start swinging the pendulum back. But the question is, how do we get there? And I don't think we got there. I hope we didn't get there with malintent in our hearts. So these are cautionary isms that I've always worn in my head as a deformity-trained surgeon who does predominantly spine. When you're operating the spine, you are either treating or causing deformity. Well, that may be true, but it also has an inflammatory or an inflationary or an escalating aspect to it. So you think that way, when am I going to treat a deformity? I would think we also need to think the other way. When am I not dealing with a deformity? When can I deal with just these degenerative things? So, I meant to go back. So the Schwab classification to me is fabulous. So that's part of the early part of the opioid crisis. We're well intended. We're trying to learn about this process. So we have this Schwab classification. And that has evolved, as we just saw Andrew talk about, into further and further differentiating. And I actually think that is ultimately the answer of really trying. Science will bear this out. But at this stage, we're in a bit of a transition in really understanding what I feel is an extremely unique patient to come into our clinic. The bigger problem to me is there's a lot of abnormal looking x-rays and a lot of excuses for escalating this care. So our colleagues in education, and we're often doctors, lawyers, always put together, and someone with a great understanding of the law can literally use the law as a weapon. Someone who has the ability to do a T10 to the S1, boy, that's somewhat a weaponized ticket. It really is. It's a big operation. I'm humbled by how sick I can make people. I'm also humbled by how profound the positive effect can be. So it has a role. It's a question of what is that role. I find this a little daunting. This was a small study, but it was 6 degenerative surgeons, 6 spine deformity surgeons, just looking at 7 cases of adult degenerative scoliosis. Group 1, which was the degenerative group, suggested an average of 3.7 levels of fusion. So group 2, your deformity-based surgeons, had an average recommendation of 10.8 levels of fusion. So just the simple knowledge and experience of knowing how to do something escalated their recommendations. This wasn't a study of right or wrong or outcomes, but it's a natural propensity that now I have a hammer and the world's starting to look like a nail. And I do believe that's true, but it's a cautionary statement. So I Googled T10 to pelvis just to see what would come up for a talk like this. And much like Jason's first slide, just a daunting thing right out of a paper. This is a primary virgin spine and a 47-year-old who actually not only got a T10 to the sacrum pelvis with, by the way, really small iliac screws, also had a PSO in a primary spine. I don't know that I've done that. I've done it junctionally. I've done it in AS. I've done it in previous fusions. But in a primary spine, it's a tough pill to swallow because that's how that person got there naturally. So the idea of the Schwab classification and our measuring, I would offer it as it's a place to start, okay? Because what you have to find in your own mind's eye is, when am I dealing with that deformity? When is it really profound? And to me, I look at the Schwab classification as an excuse not to do a big operation. Look at my parameters, ask myself, as Andrew was alluding to, how did we get here? How did that patient get here? They're 60, 70, 75 years old with deformity. They didn't get here because of, they're not there necessarily before their deformity, but perhaps something else has developed along the line. So I actually went to AI, the chat, GPT chat, to see if they could actually, I'm a lazy guy, GPT chat, can you write my talk for me? And it generated a 40-slide presentation. It was actually pretty cool. So And then I actually went to DALL-E to see if it would make the drawings of osteotomy. If you've ever done that and played around with it, it's wild, the stuff you come back with. It's kind of new wave looking stuff. So suffice to say, I did not resort to that. But I did find this, which I found fairly interesting. Will AI have an answer for this? Well, garbage in, garbage out, but it's a lot of stuff in, and there's a lot of it's a lot brighter thing than I am. And in fact, it may already have an answer. In some cases, and I put in when should adult spine deformity be fixed versus just the stenosis. And one of the summary statements, in some cases, stenosis and spine deformity can occur together, and the treatment approach may depend on the severity of each condition, blah, blah, blah. So it actually talked about, the stupid computer's telling me, think about stenosis. Okay, so reasonable thing to do. So what's the smallest operation we can get away with and still get that patient to their goals? This is, to me, is kind of where it all started. So now we recognize this patient population, this really small patient population that has horrible deformity. And they fall out of their cone of economy, and this chain of balance and all the compensatory stuff and now all of a sudden we have this magic formula, PI equals S. So now I can sit in my office and I can make decisions on care based on my measurements. Well, that's a slippery slope because there are all kinds, and that's what I was alluding to what Andrew was saying. We're getting more understanding. We may actually figure it out, but just think of how small this patient population truly is, because that is the essence. When is it tipping over? So when the spinal alignment is out of balance, mental approaches will likely come up short. We can undertreat the patient, but when the patient's doing well, despite their deformity, you don't have to go there. A 34-year-old guy came to my office. This to me is pretty straightforward. I did that. Most of those are perk screws. He had AS. That's kind of a before-after thing. I don't think that's a really debatable thing. The only way you're going to get them straighter is to kind of correct them. But what about when the degenerative problems coexist? So this is a lady in my practice right now, 76 years old, obvious deformity. But if I took Frank's parameters to that, this is a pretty well-balanced spine. This lady's 76. This is not a new problem. What is new to her is she's got leg pain. And she's tight as can be at 3'4". I actually sent her for an ESI. She did beautifully. I'm scheduling for surgery, and this is where a cautionary tone. I put possible fusion in my recommendation. I was denied that care. And I did a peer-to-peer, and that doc said to me, we would only do a decompression. Now, caveat, they didn't have the plain films, which is kind of ridiculous, and they were basing it just on the MRI, but I actually agree with them. The 3-4 segment was a straight segment. So, in fact, I talked to the lady about doing a decompression only. So you're going to see these people. They're complicated. They are ubiquitous. So are you going to operate or no? I think this is the critical decision, because if the answer is no, I would just flat out congratulate you, because if you can treat these people non-operatively, you may be doing them a great service, number one. You're certainly doing yourself one, and you're not going down to that Pandora's box. But if you're going to operate, can you get away with decompression only? That almost sounds blasphemy up here, but that's because we've got 15 years of escalating knowledge and escalating care. So I actually went back and looked at papers in the late 90s, early 20s in preparation for this talk, because that's how we used to treat these people, and they did pretty reasonably well with low reoperation rates, as I'll show you. So are you going to decompress? Are you going to decompress and fuse? So it goes to, how do you differentiate when you just decompress or do you fuse? So you go back to this, and I alluded to this already. I like to think of this as a reason not to operate, not to do a big operation. Watch all of those different modifiers, not the coronal deformity, but the sagittal one. If they're balanced, they're balanced. You don't necessarily need to do these big operations. So this is a summary. This is just how big is the problem of adult degenerative scoliosis in our society. And you all are quite familiar with these numbers, but I want to highlight them because deformity, as you can see, ubiquitous, 68% prevalence. These are asymptomatic people. If you glean out just the symptomatic people, 90% of those are associated more with stenosis. So you're not seeing these deformity problems as being primary problems in any meaningful numbers if you look at a broader number, and yet the x-rays themselves can be quite compelling. So that the deformity is actually the primary problem is fairly unusual. So this is what I was alluding to, going back, decompression alone, decompression and posterior fusion, and only when the spinal balance is out of whack are the operations recommended. Errors in spine surgery. I talk about this all the time with patients. I can undertreat your spine. I can overtreat your spine. I'll use this time to throw my bias on what Jason presented as his index operations, as his case discussion. L3-4, L4-5 stenosis in the setting of a curve. Patient did well for a week after that. That's what he said. That to me means something. That means that surgeon was operating in the right place, likely doing the correct neurologic operation. Should that then be escalated to something huge? First of all, when should you do it? How quickly? Not week 2 by any means. Give the patient a chance to recover. I would treat that with an anterior interbody, 3-4, 4-5, and posterior perc screws. Try to get some diaphragmal height back up and then move on. No way would I think about addressing that deformity. The patient already told you the answer. Had a decompression, did well. Nerves were happy. Let's try and get back to that point. Oh, I meant to say, overtreating much more insidious. Why? Human beings tolerate this stuff. It's unbelievable. They want to get better. They're motivated. I do find deformity patients pretty motivated people. And I said my lower point there, we're paid to operate. So we've got a lot of reasons here of escalating, and it's hard to know where you're wrong. I guess I'll word it that way. And you may not be. So there's a challenge. So I would encourage anyone who's training, particularly if you're under 40 going through this, because you've learned all this stuff that's escalating, probably escalating the way you think about these deformities. Think about how many people are out there without pain that have the deformity. So if you happen to see these x-rays, be careful what you're operating on. And if you see stenosis, and with injections you can identify that the stenosis is a predominant problem, do a decompression infusion. Think about anterior interbody with perc screws. You have to live with that decision. This is the Wang study from 2015. These are all lumbar sacral fusions. No sacrum. All between L1 and L5 with varying levels. And what happened? The short fusions did not correct the deformity very well, and the junctional problems persisted. You were looking at ugly x-rays. You'd watch that degenerative disc at the 2-3 level, whatever was above it, and you'd watch it. It would tip a little bit more, get a nice big spur on it, look kind of ugly. Oh, I should have done the whole thing. But look at the re-ops, 2 out of 23. Look at the VAS-ODI. You're still getting someplace with these people, and you're avoiding enormous operations. Another way of looking at it, 173 patients degenerative scolies, 81 decompressions only, so you can see the surgeon's bias here. 53 short fusions, 39 long fusions. Bottom line, all groups benefited from surgery. Look at the reoperation rates. Decompressions only 7%, short fusions 15, long fusions 28. So the idea that I need to fix everything I see in front of me is actually creating more problems. So the question is, can you get away with something smaller? So I have some guidelines. Progression to 40, progressive deformity. We talk about that in kids. It is an indication for surgery in kids. I don't care if an adult progresses. I actually tell them I don't want to see them back unless they have a problem. This is a pain-motivated operative decision. If they fall out of balance, sure, fix them. I don't even like that one. Neurogenic claudication. See if they're stenotic. If they're stenotic, in the interest of time also, because that was a tweener. That's someone with back pain and stenosis, and then buyer beware, frankly. This one's a little more clear to me. You have stenosis, you have a deformity coexistent, treat the stenosis. In general, fuse the segment you're decompressing, particularly if it's a part of the deformity. If it's below the deformity, think about just decompression only. If your sagittal parameters are okay, don't fuse down the pelvis. You don't need to. So a couple real quick cases. All these cases are 5 years old, and I have not reoperated on them, so I did cherry pick here. Decompression, fusion, the lower back, 4-5 only. Same thing, ugly looking curve. This one I showed because the junctional disease I've watched over the years coming above that fusion. It's ugly, don't get me wrong. I don't like looking at it, but the person's doing fine. Has not escalated the care. This is just identify a pain source. That is a standing x-ray on the right. That's how this person walked in my office. What are the pain generators? Pretty crummy step-listhesis. That's when she laid down for MRI, laid out nicely. That's all I did, just address the pain sources. Big operation though. I just showed this because it's more recent, but it's an anterior perc with posterior. Did a reasonable job rebalancing. Definitely addressed her stenotic symptoms. So back to this. Look at the bottom that's highlighted. It is important to consult with a spine specialist who can evaluate the patient's condition and recommend the most appropriate treatment plan based on the individual individual needs. So this is on us. We are the gatekeepers and those best suited to protect our patients from overtreatment. So is the deformity a functional issue, and what's the smallest operation I can get away with? Thanks a lot.